Good morning, students. Once again, welcome to the class. In the last class, I was telling you about the meningitis and various types of meningitis, and we have discussed about the acute bacterial meningitis and its pathogenesis, causative agent, and lab diagnosis. Today, in the second part of this particular topic, I am going to discuss about the different aspects about the chronic bacterial meningitis. As the word indicates, the chronicity is depends on the time period of the infection to occur. So here, the entire causative agent, its pathogenesis, and laboratory diagnosis will vary, and it has got a difference from the acute meningitis. So coming to the topic, I will discuss the chronic bacterial meningitis is mainly include the following. It is mainly by the bacteria. When it can occur, it is mainly occurring when there is a partially treated pyogenic meningitis is there in the patient, or a patient is already suffering with acute meningitis, and if it is not treated properly, it can lead to the chronic bacterial meningitis. Some of the infections, which include the parameningeal region like otitis media, which also can lead to the chronic bacterial meningitis. Bacterial agents like Mycobacterium tuberculosis, Borrelia burgdorferi, Treponema pallidum, Nocardia, Actinomycetes, Trophirema wipfeli, Leptospira, and Brucella also can produce the chronic bacterial meningitis. So we will study about this in detail. What are the clinical manifestations? It is almost similar to that of the acute bacterial meningitis, persistent headache, and neck or back pain, stiffness of the neck. That is a common thing what you can notice. As I told, it is similar to pyogenic meningitis. Sometimes accumulation of the CSF in the ventricle, which will lead to hydrocephalus, and that will in turn lead to the increased pressure inside the skull, and the clinical manifestations also will be shown by the person because of this hydrocephalus condition. Sometimes cranial neuropathies also can be formed like facial weakness, double vision, diminished vision, papilledema, optic atrophy, and hearing loss also can be seen in case of chronic bacterial meningitis. Myelopathy or radiculopathy leads to arm or leg weakness or numbness. Sometimes urinary retention or incontinence also can be seen because the nervous system is involved. Changes in the personality, altered mental status like drowsiness, inattention, disorientation, and memory loss also can be seen in person who is suffering with these infections. So we will study about this organism which causes the infection in detail. Mycobacterium tuberculosis infections of the central nervous system is the leading cause for the chronic bacterial meningitis. Tuberculosis of the central nervous system, almost 5% of the extrapulmonary cases, we can see this particular CNS infection. So it is seen almost often in young children, but also develops in adults who is infected with HIV. So as a co-infection of this HIV infection, tuberculosis is seen in patients who is HIV positive, and among them, this tubercular meningitis is most common. Tubercular meningitis mainly produced by the Mycobacterium tuberculosis, again classified into two clinical forms. One is tuberculous meningitis and tuberculoma. What is tubercular meningitis or TBM? TBM results from the hematogenous spread of primary or post-primary pulmonary TB. So the organism from the primary area, it is mainly from the lungs through the bloodstream, it can be transmitted to the brain or the meninges. Disease evolves after 1 to 2 weeks or longer. That is the usual incubation period. Here also, the person may experience headache, slight mental changes, low-grade fever, malaise, night sweat, anorexia, and irritability, and evolve acutely with severe headache, confusion, lethargy, altered sensorium, and neck rigidity. Sometimes cranial nerve paralysis, ocular nerve in particular. This is a frequent finding in case of the tubercular meningitis. Stroke also may be seen in some of the person who is due to the involvement of the cerebral arteritis. Ultimately, the patient will progress to coma, hydrocephalus, and intracranial hypertension. What we can do in the laboratory diagnosis of this particular tuberculous meningitis? So, as I told earlier, CSF analysis is the best method to diagnose this tubercular meningitis. So here, because it is a chronic infection, you can see leukocyte count that is mostly lymphocytic, up to 1000 per microliter of CSF. You can see neutrophils are elevated in the acute earlier stages of the infection, but later changing towards the lymphocytic content. Protein content is almost 100 to 800 milligram per deciliter. Low glucose concentration, as like in the acute meningitis, you can notice. And one special feature what you can notice in the case of this tubercular meningitis is cobweb coagulum formation. So here is the particular change what we can see in the CSF. When it is kept for more than 12 hours, a coagulum forms in the form of a cobweb on the top of the CSF, which is mainly because of the higher fibrin content in the fluid. So Mycobacterium tuberculosis is the acid-fast bacteria, so we can direct a smear of the CSF can be stained by acid-fast staining, which will demonstrate you the long, slender, beaded acid-fast bacilli that will give the conclusion that the organism, the infection is due to Mycobacterium species. As a second part, we can do the culture of the CSF. That is a gold standard method in the conventional media like Levinson-Jensen medium, which will take 4 to 8 weeks to form the colony. And in automated liquid culture medium like Mycobacteria growth indicator tube MGIT, we can get an organism in 2 to 3 weeks. Even nucleic acid based methods like gene expert assay, that is a PCR based method where you can get a result sensitivity up to 80% in case of the diagnosis. And also for the supporting studies, we can do the CT and MRI of the brain where the hydrocephalus conditions and abnormal enhancement of basal systems can be observed. That is a supportive test for the confirmation of this particular disease, that is tubercular meningitis. How to treat this particular infection in the for the patient? How we can treat the patient? The treatment is initiated immediately upon the positive result, which is obtaining in the gene expert mission or other finding. Negative result does not exclude a diagnosis of TB and requires further diagnostic workup. So the patient is showing the symptoms of the infections and you are getting a negative result in the laboratory diagnosis, does not exclude the possibility of the tubercular meningitis in the patient, and further we have to test with other sensitive tests to diagnose the infection. Patient may respond very well to the antitubercular therapy if the treatment started early. Adjunctive glucocorticoid used to reduce the CSF pressure, resulting in faster resolution. So, complication arising due to the increased intracranial pressure also can be reduced by the use of glucocorticoid therapy. The second clinical forms of tubercular meningitis is tuberculoma. It is a very uncommon manifestation of tubercular infection of CNS, present as space-occupying lesion, firm nodule with a central caseous necrosis, causes scissors and focal signs. So apart from the other symptoms, what I thought person may develop scissors because of the space-occupying lesion. For the laboratory diagnosis, CT or MRI with contrast enhancing ring lesions can be done, but biopsy is necessary to establish the diagnosis and to differentiate it from malignancy. The second most common bacteria which produces chronic meningitis is neuroborreliosis. It is also called as the Lyme disease. It is mainly produced by Borrelia burgdorferi, transmitted by tick bite. So cutaneous lesions and arthritis may lead to the CNS infections. Manifestations include meningitis, subtle encephalitic signs, cranial neuritis, bilateral facial palsy, and radiculoneuropathy also can be seen. In the case of neuroborreliosis, CSF findings, again, elevated lymphocytes, elevated protein levels, and normal or slightly low glucose level. Meningopolyneuritis, which can be seen in the case of neuroborreliosis, where radicular pain with a CSF leukocytosis without meningeal or encephalitic signs, that is called as Van-Wart syndrome, which is a special feature that you can see in case of neuroborreliosis. So this particular infection resolves completely within a month, but rarely chronic neurological disease may occur if untreated. So for the treatment purpose, we can start intravenous injection of ceftriaxone for 14 to 28 days. Alternatively, intravenous cefotaxime or intravenous penicillin G can be given to treat the patient. The third important causative agent of the chronic meningitis is the Treponema pallidum, where in the stages of the syphilis, neurosyphilis is a condition where you can see this particular complication. Neurosyphilis is occurring during the tertiary form of the syphilis, develops about 10% of the patient who is untreated for syphilis. Syphilis is, as you know, it is a sexually transmitted disease produced by Treponema pallidum. The bacteria may invade into the CNS early within first few weeks of infection, followed by years of asymptomatic period. So usually this particular complication you can see in the late tertiary stage of the infection. So what are all the clinical manifestations you can observe in case of this particular neural syphilis? Asymptomatic neurosyphilis, meningeal syphilis, meningovascular syphilis, general paralysis of insane, and stapes dorsalis are the clinical manifestations. For the laboratory diagnosis, we have to do the CSF analysis, where again you can see the increased lymphocytes and decreased protein level because of this particular WBC is present. VDRL test with the CSF is a other alternative technique what we can, or lab test what we can perform. It's a non-treponemal test, detects antibodies against the cardiolipin antigen derived from the bovine heart. Fluorescent treponemal antibody absorption test, that is also a test which can be done to confirm the neurosyphilis. PCR-based studies will give a prompt result for the diagnosis. Treatment of neurosyphilis is mainly done by aqueous crystalline or proctine penicillin G is given for 10 to 14 days. Retreatment if non-treponemal titers in CSF do not decrease by fourfold within 2 years of completion of treatment. Patient with penicillin allergy, desensitization to penicillin has to be done, following which the penicillin can be administered. So that is about the two forms of meningitis. that's the acute as well as chronic. So in the next class, we will start with a new topic, which is again related to the central nervous system. Thank you so much.